It's just of mine and Philip's screen only, so none of you are being recorded. And I think that's it from me. So please enjoy the session. And Philip, it's over to you. Welcome.
Yeah, thank you. Hi everyone. Thank you for joining the webinar, and thank you, Nikki, for inviting me. So today I'm going to talk a bit about Temporal Mandibular Disorders, or otherwise known as TMD, and Ehlers-Danlos syndrome. So introduced by Nikki there. So I'm Phil Bateman. I was an extended scope physiotherapist working at Sheffield teaching hospitals. I was based at the Royal Hallamshire Hospital in the musculoskeletal outpatient department, and most of my patients came from the Charles Clifford Dental Hospital across the road, with a working diagnosis of TMD. I also worked at the Charles Clifford Dental Hospital in a TMD clinic with Professor Loescher at that point. Now, however, I have moved from last year, moved up to Scotland with my family and relocated, and now I'm working in a small practice just outside Stirling, still seeing mainly TMD patients. So I'm going to try and answer some questions which I hope will be helpful to you. The first, what is TMD? What are the symptoms of TMD? How common is TMD? What is the cause of TMD? Is TMD associated with EDS? How is TMD diagnosed? What are the guidelines for the treatment of TMD? And how do physiotherapists like myself treat TMD? So starting with what is TMD? I'm going to use a simple definition, which is it's a term used for a number of problems that involve the jaw chewing muscles, particularly the big closing muscles, masseter and temporalis, and also the jaw joint, otherwise known as the temporal mandibular joint, or TMJ. What are the symptoms of TMD? Well, we'd expect patients to present with pain and tenderness over the jaw joint and the jaw muscles. Usually, pain is worse with jaw activities such as chewing. Many will come with reduced mouth opening and joint noises such as clicking. The problems may occur on one or both sides. And what we really do know is that persistent TMD symptoms can significantly affect quality of life. How common is TMD? Well, in the general population, we'd expect about 1 in 3 people to experience TMD in their lifetime. Those with more persistent symptoms requiring treatment is about 1 in 20. So we can see that TMD is very common in the general population. What is the cause of TMD? Well, rather than a single cause, usually TMD involves multiple factors. A complex combination of biological, psychological, social, lifestyle contributing factors. Some commonly associated risk factors or contributing factors include jaw trauma, genetic factors, so some of us are more vulnerable, genetically vulnerable to these types of conditions, increased sensitivity of the body's pain alarm system, having other pain conditions such as headache, neck pain, or fibromyalgia can contribute. Emotional stress at home or work. Psychological conditions such as depression and anxiety. Excessive oral behavior, things that you do with your jaw or your mouth, either in your sleep or while you're awake, such as grinding the teeth, clenching the teeth, chewing gum, biting your nails, etc. We'll look at this a little bit more later. Poor sleep quality and sleep disorder breathing, such as obstructive sleep apnea. And each patient will present with their own individual set of factors. With persistent TMD, the various contributing factors act together to maintain an ongoing cycle of pain and disability. So long-term successful management will usually depend on identifying that patient's specific contributing factors and trying to minimize any modifiable factors to help break their cycle of pain and disability. Is TMD associated with EDS? Well, the answer to this appears to be yes. The EDS population has a higher prevalence of TMD compared to the general population. So earlier we said the general population would expect about 1 in 3 people to have experienced TMD. The current literature suggests that in the EDS population, this is more likely to be about 2 in 3, significantly higher. The reason why individuals with EDS are more likely to develop TMD is poorly understood. However, it's likely to be due to multiple factors. In addition to other factors, joint hypermobility, that's increased flexibility or increased laxity of joints, may be a significant contributing factor in the EDS population. Joint hypermobility is more common in TMD patients, and we know that it's a key feature in EDS and often involves the temporal mandibular joint. TMJ, or temporal mandibular joint dislocation, appears to be more common in the EDS population. It's thought that joint hypermobility might contribute to the development of TMD due to reduced joint control and recurrent injury. How is TMD diagnosed? Well, we know that early diagnosis helps prevent development of more persistent TMD symptoms, and a delay or lack of certainty is likely to increase intensity of symptoms and cause psychological distress. Assessment will usually be performed by your dentist, your GP, or your physiotherapist. And diagnosis will usually be provided after a thorough discussion about your symptoms, plus any potential contributing factors, and then a physical examination. Diagnosis is usually classified into a joint TMD, a muscle TMD, or a mix of both. And any potential contributing factors are an important part of that diagnosis. Further investigation for TMD is not usually necessary. However, a small number of individuals may require various imaging for definitive diagnosis. What are the guidelines for the treatment of TMD? Well, guidelines for safe and effective treatment recommend using conservative, less invasive treatment strategies, such as education and advice about the condition, physiotherapy, splint therapy, that's mouth guards usually worn at night, medication, and psychological support or therapy. These strategies have been proven to reduce TMD pain and improve jaw function, and we'd expect the majority, around 70 to 90%, to significantly improve. Now, research specifically on EDS patients with TMD is pretty scarce. From the available research, it appears that the majority respond well to conservative treatment. However, better designed studies are needed to develop more specific guidelines. In a small number of individuals, more invasive treatment strategies may be considered appropriate, such as injection therapy and surgery. As a physiotherapist, I'm going to discuss education and advice and physiotherapy a little bit more. So, how do physiotherapists like myself treat TMD? Current guidelines strongly recommend specific strategies used by physiotherapists. So education and self-management has been strongly recommended for joint TMD and muscle TMD. The aim is to help patients make more sense of the disorder, which hopefully will reduce the threat of their symptoms, provide some rationale for treatment, and can help to reduce pain. Manual therapy, such as massage techniques and manipulative joint techniques, exercise therapy, postural training, have all been strongly recommended for both joint and muscle TMDs, with the aim of reducing muscle tension, improving joint control, reducing pain, and restoring movement and function. And finally, acupuncture as an adjunct, an additional treatment to other treatments, is strongly recommended for specifically for muscle TMD. So reducing muscle tension and reducing pain. So I'm going to take a look at some useful self-management strategies. And these have been taken from information that was developed by myself, along with the Sheffield teaching hospitals. And the first is identifying and reducing excessive oral behaviour. As we know that excessive oral behaviour appears to be a common feature of TMD. So this identifying and reducing excessive oral behaviours are split into three parts. The first part is regularly checking your relaxed jaw rest position, particularly avoiding any excessive tooth contact. So if I'm asking somebody to check their rest position, they need a reference point of what normal rest position is. So the teeth should be apart, and if you all say the word Emma, at the end of the word Emma, your mouth should drop open slightly, or your teeth should be about 2 to 5 millimeters apart. Contacted teeth will activate the masseter muscle and temporalis muscle, which are usually painful, and compress the joint. If you look at a child, or if you could look at a young child inside their mouth when they're at rest, their teeth are always slightly apart unless they're doing some sort of activity such as chewing or talking. The tongue on the roof is usually on the roof of the mouth, just behind the upper teeth in what we call the clucking position. So if I make a cluck sound, the tongue usually gently just rests on the roof of the mouth, just behind the top teeth. If you can't make a cluck, you can make the sound of a letter N, like N for Nigel, N, N. So it's either a cluck sound or a N sound, and that's where the tongue, with most people, usually rests. So you should, for a few days, I'd recommend just checking that your teeth are slightly apart and your tongue is up, and if not, correct them if you're at rest. The second part of the strategy is to use something called the oral behaviour checklist. So on the reverse of one of the information leaflets, we've got the checklist here. And this, on the oral behaviour checklist at the top, it suggests that you look at the list once a day for around about a week. That's just to become more familiar with the various oral behaviours, things that you do with your mouth and your jaw. And after a week, then you fill in the relevant boxes, and these are the frequency boxes. So it should help you identify any excessive oral behaviours. The final part of the strategy, and probably the most important, is then to download an annoying repeat reminder app. And you can either download this fairly old app, the No Clenching app, or there's various apps that you can get repeat alerts on iPhone or your Android from Apple or Google Play. And what you do is you set these apps to go off about once every half an hour. And when the app goes off, you check your jaw rest position, make sure you're not doing any of those habits. And if your jaw rest position isn't correct, you correct it. Obviously, if you're chewing or talking or doing any normal activities with your jaw, you just ignore it. Now, this will help you consistently monitor and correct and reduce any excessive oral behaviors. The benefit of using an app is that some of these oral behaviors that are habitual, you tend to do when you're stressed or when you're concentrating. And when you're stressed and concentrating, you won't usually be thinking about your jaw. So what these apps do is drag your attention just for a few seconds so you can actually correct your jaw rest position. The other benefit is that over a period of time, we suggest you use this type of app for about 6 to 8 weeks. And over that time, patients come back and tell me around about 4 or 5 weeks' time, when the app goes off, more often their jaw is in the correct position of teeth slightly apart and tongue up. So you can actually monitor progress. So the next strategies are to look at reducing muscle tension, and I'm going to go through a relaxation technique and a massage technique. So, and the aim of these is to, we know that increased muscle tension appears to be a common feature of TMD. So starting with the jaw relaxation technique. The aim of the technique is really, what you're trying to do is you're trying to put your teeth and your tongue in the correct position. You do something called diaphragmatic breathing. That's breathing slightly slower and slightly deeper into your tummy rather than your chest. And on the breath out, what you're trying to do is use a bit of imagery to try and help your muscles, your jaw muscles relax. So maybe think about your cheek muscles sort of relaxing, the tension melting away, or whatever kind of helps. And what this is supposed to give you is a reference point after doing this for a week or two, is a reference point on what it feels like to let go with your jaw muscles. Then what you can do is, in addition to actually checking your jaw rest position of teeth apart and tongue up, you can also check for any muscle tension in your jaw, otherwise known as jaw bracing. The next technique is a simple massage technique. And what you do is you start with this technique for a short duration, maybe of 1 minute or so. You're trying to do it 3 times a day, maybe after each meal, so you're consistent, or after you clean your teeth. And you gradually build up the duration first, getting up to about 4 or 5 minutes, and then you can increase the intensity of the massage. Now, it's really important that you avoid any significant pain when you're doing the technique, so mild increase in pain, moderate at most. And after the technique, probably more importantly, is that you avoid any prolonged periods of increased pain. So I'd expect within 10 to 15 minutes that your pain returns to where it was before you started or better. And why that is because if you're increasing your levels of pain significantly when you're doing the technique or for long periods afterwards, you're likely to increase muscle guarding, which is not going to help. What we're trying to do is relax the muscles and desensitize the muscles. So I'm going to try to demonstrate this technique to you so you can have a go. So I'm just going to give you a few tips on the technique. So what I'm going to do is I'm going to rest my arms on my chest so they're relaxed. You can put your arms on the table or whatever if you have problems around the shoulder area. Then I'm going to place my fingers, flats of my fingers on my cheeks. and my fingers are together and just lightly onto my cheeks, and my index finger is going to point to the bottom of my earlobe. Now, if my hands are in this position, I want to just cup my hands slightly so my heels of my hands come together a little bit, or it's slightly separated, whatever is more comfortable. But then I'm going to put a little bit of pressure on my cheeks, and I'm going to then clench. Now, the only reason I'm doing this is what I should feel into my fingers is some slight bulging. Now I know that my fingers are over the masseter muscle belly, which is in this kind of just above the corner or the angle of the jaw. And now what I'm going to do is I'm going to keep in contact very gently and just move my fingers in a circular direction, and it doesn't matter which way you go. And I'm going to keep it very gentle, only enough contact to actually move the skin over the muscle below. There's a lovely smooth interface. You don't need any creams or oils at all. And you repeat this and continue this for about a minute. And then over the next few weeks, you're trying to build up nice and slowly the duration. And once the duration, you get in a reasonable duration as the muscle relaxes and desensitizes, then you can actually get a little bit deeper into the muscle, but really respecting pain. You don't want too much pain. Okay, so that's now the next strategy is an exercise to improve jaw control. So it's with poor jaw control, it appears to be a common feature of TMD, especially with joint hypermobility. So this technique is trying to improve that control. The actual technique has been around for about 50 years, and its nickname is the goldfish exercise because you're supposed to look like a goldfish, and it's supposed to be a goldfish in slow motion. So it's a slow, smooth opening and closing movement, and you're trying to also avoid any excessive forward movements of the lower jaw. So I'm going to try and demonstrate this also. So if you could always try this at home. I'm initially going to place my tongue on the roof of my mouth to help to facilitate a bit more control. So it looks like that cluck position, which is tongue stays on the roof of the mouth throughout the exercise very gently, and then I'm opening and closing my mouth very slowly like this. And if I look from the side, what I want to prevent is any excessive forward movements of the jaw, and I also want the movement to be nice and slow. Now, the things to look at, the other thing to look out for in terms of how smooth the jaw, often patients with what we call co-contraction, where the muscles are kind of working against each other because they're kind of guarding the area. The big, powerful masseter and temporalis are overactive, and these little muscles are trying to pull the jaw down. And what you tend to get is more of a jerky, ratchety type movement, or an all or nothing open and close. So what you're trying to do is correct that and remind the brain that it needs to let go of these muscles for you to open the jaw without so much tension. So, so that should look like this nice slow movement. So a goldfish in slow motion. Now, one of the ways you can actually usually help that is if you place the finger, your index finger, on your chin and do the same exercise. So I'm going to place my finger on the chin, and I'm going to actually keep my tongue up, just as I was doing before, and then try the exercise again. Now the finger is just leaning against my chin. It's a slight pressure only. It shouldn't be a push, okay, because you'll push the jaw joint into its socket a bit more, and that can be painful. So it's a guidance. So it's a lean of my finger on my chin in a backward direction, and I'm going to do exactly the same thing. Now, when many people do that exercise, when they have TMD issues, what tends to feel better and smoother and looks better is is with a bit of support. So that's what I try the two and see whichever moves better or feels better. That's how I do the exercise. So now, what my suggestion would be is to start with identifying and reducing excessive behavior initially, maybe spend about a week or two on that, and that's knowing your jaw rest position, practicing that. For many people, it won't feel normal to them, but after a bit of practice, it will start to feel normal. Then using the oral behavior checklist just to check for any other excessive behaviors with the jaw, and then finally using the app. So that's how I'd start in terms of the first week or two. And my suggestion then would be to move on to the relaxation and massage techniques, keeping them the massage very gentle and the short duration to start with, and then building up the duration first and then the intensity a bit later. And then finally, after a couple of weeks, maybe add on the jaw control exercise. Usually that'll be added straight onto the massage. So you do the massage 3 times a day and the jaw control exercise straight after, and that's just a 10 repetition exercise. So the exercises shouldn't take much more than 5 minutes, and you try to do those consistently. And the combination of trying to reduce any causative oral behaviors that might be excessive and trying to relax your jaw by doing the massage and the relaxation and then getting better control. Hopefully, for most patients, that can be very helpful. Now, if you're interested in further physiotherapy, what I would suggest is that you see a physiotherapist that has a special interest in TMD. And one way of locating these is to go onto the Association of Chartered Physiotherapists in Temporal Mandibular Disorder, as well as this website, as well as giving you further information about TMD, also has a section where you can actually locate various trained physiotherapists, hopefully near to yourselves. Now, if significant symptoms persist, despite these conservative measures, your dentist or GP may consider referring you to a local dental hospital or maxillofacial department, hopefully for multidisciplinary team care, which should consist of a confirmation of your diagnosis, more specialist pain management, and for a small number of individuals, they may consider more invasive strategies such as injection therapy and surgery. So I'm hoping that just answering these questions has been helpful for you today. I have got some links at the end here that I can pass on to Nikki regarding TMD management guidelines if you're interested in looking at these a little bit more, and also to some of the literature on TMD and EDS, although there's not a great deal out there at the moment. And finally, I've also forwarded some of the patients' information sheets to Nikki, so if people are interested, hopefully we can make those accessible. So I'll finish there if there's any questions anyone has.
Thank you, Phil. That was really, really interesting. I'm sitting here doing all those exercises along with you. So thank you. We've had, as you can probably imagine, tons of questions. So I'm going to try and kind of group them into sort of themes if I can. So the first question that's come up quite a few times is it necessary for a physio or a dentist to be trained in EDS to properly assess and diagnose somebody with TMD?
So, I mean, that would be ideal, but no, really. I mean, if you've got training in TMD and I know something about EDS, I think there's not, it is helpful to know things about EDS, but from each patient I learn different things about EDS all the time. So I think it is helpful to know something about EDS, but I don't think it's essential, because what we're looking for in all patients is what we call impairments, things that the patients are struggling with, and we try to treat those directly. So whether you've got EDS or haven't, there's lots of people out there with joint hypermobility that haven't got EDS that I might be treating in a similar way. And hopefully it's effective for both lots of patients.
Lovely. One of the questions, we've had this a few times in different ways. So due to grinding or various different reasons, lots of people seem to have either an overbite or an underbite. So the teeth don't kind of rest in that sort of natural position that you were talking about. Would they have a different natural resting position for their tongue?
So, regarding the overbite, or there's two terms that we all get mixed up, clinicians and physios. One is the overjet, which is I've got a skull here. So the overjet is the teeth, upper teeth coming slightly more forwards than the bottom teeth, and the different what we call occlusions, the way the teeth meet together, have different classes. There's 1, 2, and 3. So this would be a class 2. There's an underjet, and that'd be described as class 2. Now, I am not a dentist, so this is very basic stuff that I'm talking. I'm not trying to be a dentist either. And the overbite is more to do with how far the teeth actually overlap. Now, the occlusion, the way the teeth line up, shouldn't really affect particularly the position of the tongue and the teeth when you're in normal rest position. When I say the word Emma, at the end of the word, the main thing is that none of the teeth are in contact. There's a 2 to 5 millimeter gap between the teeth, because we don't want teeth to be touching. If the teeth are touching, it will activate the very muscles that are usually painful and overactive. So the important thing is there's a slight, and that doesn't always feel right for patients. Many patients come in and they feel that their normal position is the teeth are actually connected. And that is probably perpetuating, or one of the factors that might be contributing to a perpetuation of their problem. Now, the tongue position, very basically, it's behind the front teeth, in that very gentle hook or nip position. And it's likely that the tongue is just giving a bit of extra support, because it's a muscle, to the jaw, so the other muscles can relax a little bit better. However, not everybody has their tongue on their roof of the mouth, and particularly people that kind of breathe through their mouth might have their tongue resting on the floor of the mouth. And it's probably of secondary importance, the tongue position, compared to where the teeth being separate. But most patients come back, and if they've been trying this position, say that it eventually feels a lot more relaxed to have that what we consider more normal rest position.
Lovely, thank you. We've also had quite a lot of questions around ears, hearing loss, eustachian tubes, ear infections. Could that be related to TMD issues?
Okay, so I know that from my own clinical experience, and also from the literature, that I would expect over half of my patients to come in with ear type symptoms. Now, if somebody's got ear symptoms, we want them to be screened for local ear problems. However, many of them already been seen at GP and been to ear, nose and throat, and then come to me and they've ruled out an ear problem, and many of them have also been told that's probably associated with their TMD problem, because we know that these symptoms can be referred to the ear. So it feels like something's going on with your ear, but it's more related to your jaw problem. And what I tell patients is that by treating the jaw, many of the patients, some of these symptoms will reduce, but we can't guarantee that. However, in my own experience, that's usually the case. Many of these symptoms are, if it's related to their jaw problem, tend to reduce. So yes, there's a lot of these symptoms. I've got I'll just I've still got my slides up, haven't I?
Yes.
So this is the kind of the referral pattern just from the masseter muscle. And you can see that from even just the masseter muscle, my patients will come in with sinus issues. They've been to ear, nose, and throat, and it's ruled out they've got no sinus. So they've got pain over the sinus area, pain into the teeth or over the teeth and the gums, even extracted teeth sometimes, which didn't help the symptoms. So we know that, and the ear is probably the most common symptom. Ear pain, I expect many of my patients come with ear pain, and even headache from the masseter muscle over the eye. So these referral patterns are very confusing for both clinicians and patients, and we can't ignore them. But first thing, we need to screen for the actual source of symptoms. So if someone's got sinus pain, we want to make sure they've got no sinus problems and ear pain, etc. But these are common referral patterns that confuse us. Does that make sense? Hopefully.
Thank you. Lots of questions around dentistry, obviously, because it's that area. So questions around quite a few people who go to the dentist for their regular checkups, but when they need to have something done, they can't open their jaw wide enough or keep it open without severe pain. Is there something that they can do to help that?
Okay, so I'm going to come from my experience of listening to dentists and consultants and what they tell me in terms of advice. So I know the consultant I used to work with, Professor Losher, she used to write the letters back to the dentist, and she'd always recommend, or with many patients, she'd recommend using a dental prop or a dental wedge. So this is something that the person, the dentist or the clinician, whether it's a dentist or a hygienist, can put into the opposite side of your mouth between the teeth, and it's just a wedge. And you rest your teeth on that wedge while they work on the other side of the mouth. Now, that usually takes away some of what we call the co-contraction, so muscles working against each other and extra tension. So being able to rest on it, often people can be less sore and less tension going through the muscles when you use a wedge like that. And breaks. The patients need breaks, so if you tell your dentist that you have got a jaw problem and you really are struggling to keep your jaw open for longer periods, they may book you into a longer period. Now, probably dentists are going to hate me for saying that, but in the ideal world, that's what should happen, is that you get a bit longer, you can take breaks, and also maybe try the dental wedge or a prop. Those things might be helpful, and also doing some treatment, trying to reduce some of that tension in the first place might be helpful.
Lovely. And what about sort of sticking with the dentist orthodontist kind of way? What about, if people have got TMD, TMD, and they get is straightening their teeth, wearing braces, getting work done to kind of realign their teeth, can that help?
So the evidence suggests that a thought in the past was that would be helpful. Okay, so the current evidence suggests that for occlusion, the way the teeth fit together, is not a major contributing factor to TMD. So it's something that most evidence would suggest that's not the way forward to make these kind of irreversible changes and they're not needed for most people. Now, if you just had a recent tooth, like a filling or something, and your jaw doesn't feel like it's fitting together properly, that might be a different matter. Now, I am not a dentist, and I think so this is an area outside my scope. However, these are the kind of experiences that I come across, and also I've obviously been in clinic with various consultants and other dental clinicians, and this is what I hear. And the literature, I do read lots of literature, and I know that the current evidence is that occlusion isn't something, the way the teeth fit together is not something that is something that they'd go directly to. They have some awareness of it. We can't exclude everything, but it's not the first thing that that we'd be thinking of changing really with most people.
Lovely. And with regards to the exercises that you were doing, first of all, how long should you do those exercises for? And should you, if you've got inflammation, if etc., should you wait until that inflammation has gone down before you start doing those exercises? And so, how long, how often, and should you do it if you've got inflammation?
Okay, so most people that I see, they don't necessarily have inflammation. It's more sensitization and overactivity. So you get this vicious cycle of too much activity, sensitive joints and sensitive muscles, and that's really what we're trying to break, that cycle, really. Some people do get inflammation, so the kinds of but inflammatory conditions such as rheumatoid arthritis, juvenile idiopathic arthritis, or after trauma, and also some people maybe with osteoarthritis can get some levels, but that's fairly rare that I've come across with the inflammatory problems with that. So really what we're looking at is trying to reduce increased sensitivity and activity. And why I started with the oral behaviour as a suggestion is that often one of the causative factors is that when you've got pain, many patients have pain all over the body, not just the jaw, the tendency is to express our emotions through this area, and everything tends to come tight around this area. So if we can release that to start off with as a causative factor, and in the long term reduce that significantly, we're never going to take away all the oral behavior that people do, but reducing it can start off at addressing that balance. Then gentle exercise like massage that don't increase the pain by significantly, and then gradually grading those exercises so you can actually reduce the sensitivity in a graded way, and adding that very basic control exercise, which often isn't that painful for patients to do. These are exercises that you should be able to actually, as long as you do them in small bits to start off with. Now, time-wise, doing a minute 3 times a day of massage, getting your brain used to what you're doing to this area, building it up gradually, getting up to about 4 or 5 minutes, adding these slow 10 repetitions. It might start with 5 of the opening closing exercise. So you're doing around about 5 minutes 3 times a day. And eventually what the idea is that patients stop these exercises because they've reduced some of their oral behavior, hopefully, and most of my patients that I see have got some level of excessive oral behavior. And it's a response to everything that's going on really around conditions or whatever. Reducing that for the long term can be very helpful, and all the exercises I do are just bringing everything down back to where it was before all this started. So then you wean off the exercises like you would any kind of medication or whatever, once you get control. Does that explain that?
It does. We've got so many questions. I've got a few more for you as well. If that's okay. It's so interesting. Are there so how to support how for people can support their jaw in their sleep? Some are talking about the fact they tie a scarf around their head to keep their jaw in place. Various other things. What is that? Does that work? And would you recommend that?
So,
Sorry, just to add in as well,
yeah, go on.
and what if you're wearing a CPAP machine or some kind of breathing machine as well?
Yeah,
How does that impact?
yeah, so that's difficult. I mean, we know that CPAP, if it's related to obstructive sleep apnea, we know that people with obstructive sleep apnea are more likely to have TMD
Oh, okay.
problems. And one of the theories behind that is that the actual activity that people are doing at night time with the jaw it's called sleep bruxism. Whatever people do with their jaw at night. It is related to trying to keep your brain, trying to keep your airway open.
Oh,
so,
interesting.
so things like sleep, CPAP, and there's something called uh, a device that actually pushes your jaw forwards, a mandible advancement device. I can't remember what it's called, but it pushes the jaw forward. So these types of things are trying to keep the airways nice and free, and hopefully that will reduce some of the activity that's occurring. The thing that's advised mainly for sleep bruxism, or things that you do with your jaw at night, and trying to reduce. If you're getting significant symptoms in the morning, it's likely that you're doing stuff with your jaw overnight, probably. So our splints or mouth guards, might call them, got various names, but the idea is to wear the splint at night. One, to protect the teeth, because if people are doing lots of activity, at the worst they can result in fracture of the teeth, but and that's quite rare. But also erosion of the wear of the teeth. So protecting the teeth is one thing, but also what the current literature suggests or recommends these splints for is to try to reduce some of the symptoms of temporal mandibular disorder. The problem with wearing things like a scarf around is that it holds the teeth together, and that's not really what we're particularly after in terms of that, really.
Thank you. Any specific ways to chew and eat food that can help? Because for a lot of people, there's a lot of pain around eating. Are there any sort of hints for that?
So if people are experience a lot of pain when they're eating, various suggestions. Checking that, and this is easier said than done, of course. Checking that you're chewing on both sides. Now, if you've got a particular sore side, it's the last thing you probably want to do. So it might be that you try to reduce some of the pain around that area before you start swapping sides. But the basic advice is really having a softer diet initially. Now, that should be hopefully temporary. Having a softer diet will reduce some of the loading on the and the pain, hopefully. But eventually, what we want is that with all the other measures, those other conservative measures, and other people will get a mix of conservative. They're not just just physio. They might get a splint, physio, medication, and often patients that come to me are already on various medications, or a particular medication for their TMD. They've got a splint for night time, and that combination. What we want is that things normalize a bit and reduce your pain, so you can get back to these types of function, because it's important to be able to eat, isn't it? To enjoy your food, and yeah. So in the long term, what we want is that you can go back to those activities, but in the short term, softer diet, chewing slowly and a bit more carefully is probably the.
So it's like a combination of trying lots of different things, isn't it, to try and take the.
Well, we've said at the beginning, it's a multifactorial condition, so you hit it with multiple modes of treatment is the idea, and if you can find out what's contributing, then you target those contributors, but that usually takes more than one modality, so people come to me and they're sleep bruxing. There's nothing I can do about that. I want them to go to a dentist and get their dentist to provide maybe a splint for them. People come with long periods of pain, and even when you touch the cheek, they've got something called allodynia. It's painful even to touch the area. Those patients probably need medication for that, and there's certain medications that are advised for that type of pain that affects the central nervous. They become sensitized, and to try to desensitize that to some extent. And again, these are things that hopefully you can wean off eventually, but to try and get control first, and then keep control for a while, and then start weaning off the various modalities.
And what about special pillows? Anything around those? Can they be helpful?
Yeah, so with pillows, it's really variable from one patient to another. So a patient will come in and tell me that a particular pillow has been so helpful, and then someone said, I bought 5 different types of pillow, and they're all in my cupboard, and including that type of pillow. One of the suggestions is a feather pillow, if you haven't got allergies, is probably something that you can mold a little bit better to your neck. So that might be for some people. I would try pillows from other people, family and friends, and just experiment. Because for one pillow, suits one person, we're all very different, and just trying to get something. Same with bed, mattresses. Trying to experiment even around the house, really, with different mattresses is probably the way forward, and getting a feeling whether it's a hard, soft, or medium mattress. Same with pillows, shape and what's inside them, but usually something supportive of the back of the neck can be helpful, usually.
And a few questions about Botox, and I'm presuming they mean about going sort of in that muscle to muscle rather than getting rid of your wrinkles on the top of your head.
Yeah.
Do you have any kind of thoughts on that?
Okay, so again, it's out of my scope. I don't do Botox, but I've come across it quite a lot, and it can be very helpful. However, with all the things like surgery, Botox, those type of injection therapy, so those passive types of treatments, it's recommended that you will be doing some self-management, have a knowledge of TMD, know how to try to look for your own kind of excessive behaviors, and anything else that you can target. So stress management. So all this self-management, along with those, it's recommended the self-management side of things is key, really, and then anything on top, can be helpful. So Botox is used quite a lot with maxillofacial clinics, and seems to be helpful. Not for everybody, but it can be helpful. There's still some concern about long-term effects, and we don't really know what in terms of long-term, whether there's any kind of long-term side effects of Botox. And there's risk with everything, kind of injection therapy. Yeah. But taking the advice of someone that specializes in that area, so you come, if it's a max fac surgeon that's talking to you, that's probably the best person to get that advice from, really. But I would suggest that everyone goes through this kind of self-management side of things, knowing a bit more about the condition and how to reduce some of their own contributing factors alongside any other management.
Yeah, lovely, thank you. And I'm sort of conscious of the time, so I'm just I'm really trying. I have never seen so many questions on a webinar, I have to tell you. I mean, there's just so much coming through. There's one question around, does TMD contribute or have anything to do with swallowing difficulties, which is often found in some of the EDS types?
Yeah. So again, there's lots of contributing factors to that. So screening by ear, nose, and throat, or like a speech therapist or whatever, is important. However, on some of the older questionnaires, it used to be part of the questionnaires of swallow difficulties. And what I would say from my own experience is that many patients that report even feeling that being strangled a little bit around the neck, and there's pressure around there. If you think about the muscles that close your jaw, and you close your eyes if you don't like the size of these things, but masseter and temporalis, these are big, powerful muscles. Now, they're closing muscles, and if they're very active, and these poor little muscles that actually attach to, there's a bone under here called the hyoid, so you get the muscles above the hyoid and then the muscles below attaching down the front of your neck. These are trying to work against some really powerful muscles up here, and they're only small muscles. They'll become tight and sore. They're trying to, and that will make that potentially can cause difficulties with swallowing. So usually when you treat these muscles, with my experience, some of these symptoms reduce without actually. There are stretches that you can do, like techniques that you can do on the muscles around here to help with those kind of swallow issues if it's related to their TMD. I mean, these patients need screening to make sure there's not other causes for their swallow. There's lots of other causes for swallow problems, but if it is related, they're being assessed and say no, it's nothing other than their TMD problem. Then reducing some of this activity, often patients that relieves the actual tension around the neck area.
Okay. And I'm going to finish on a last question. I do apologise to everybody. We haven't got to your specifics. I've had to try and kind of group the themes together. But the last question that's been asked quite a lot is about migraines and the links between migraines and TMD and what can be done.
Yeah. So the big three that come to me is headache, including migraine, maybe tension headache, TMD, and neck pain. Now we know that these are there's an association, definitely. Within the nervous system, there's an association. These are your head, your neck. Information goes into the same point in the brainstem. Okay, there's a crossover of information here. So various referral patterns, pain and stuff. I would expect over half my patients to come with migraine or tension type headache and neck pain. So a combination of TMD and neck pain, TMD, migraine, really common. And if you treat the migraine on its own, you'll get so far. And some people, the migraine will go away. But if they've got a TMD and a neck problem as well, treating all the conditions is what you want to do, really. You're probably going to get most progress, in my experience. And what the literature probably tells us is that treating all those, any condition that you've got, so if you've got a jaw problem and a migraine, treating both the migraine and the jaw problem is the way forward. And we're pretty sure that treating one of those things often helps the other, but treating both is what you ideally want. But yes, it's a common association. We see a lot of headache, migraine, and neck problems coming.
Lovely, thank you. It's been so interesting. I think sometimes it doesn't help, it doesn't cure it, but I think sometimes knowing the mechanics behind why you're getting some kind of issues is how to help you self-manage. So I think that's been really interesting. We've got loads of people in the chat. Just thank you so much, and to you for all of that information and sharing your expertise on this miserable, for me anyway, Saturday afternoon outside.
Same here in Scotland, exactly the same. Yeah.
Oh, is it as well? Yeah, miserable everywhere it is. But yeah, thank you so much.
Right.
Really appreciate it.
Thank you for inviting me. Hopefully it's been helpful.
So useful, so useful. And for anybody watching, the webinar will be available for members on the website probably in a few weeks' time. And I've got the bits and pieces that you've sent me through, Phil, the information sheets, and I'm going to try and work out how to send you all of those, the people who are here today, through Eventbrite. So just bear with me. I will work that out and get those to you. But yeah, again, thank you so much. Really, really useful.
Oh, thank you, Nikki. Thanks a lot. Okay.
Thank you. And thank you, everybody, for joining us. And hopefully we will see you for the next one. Take care, everyone.